Welcome back to the Ninja Nerd Podcast. Today we're talking about diuretics. Lots of diuretics. We're going to diurese like no other.
Yeah, I love diuresing.
Why?
Because it's just so nice. I love like a patient coming in being swollen as ever, and I can just like pull and strip like 10 pounds off of them. I wish I could do that to myself. I should just start diuretic.
Can you try and do that to me?
Yeah.
I'll be peeing all night.
Yeah.
But diuretics, though, it's a cornerstone of any therapy, really.
Yeah, especially in the hospital, in the emergency department, ICU. It's definitely something that, as a resuscitationist, they should definitely know how to
you better know it.
Yeah.
Okay, so we're going to take a case. We're going to kind of analyze it, go through it step by step, kind of like IV fluids. If you check that episode out.
Yeah.
So let's begin here. We have a 65-year-old woman presents to the ED with severe swelling in her legs, difficulty breathing, and generalized fatigue. The patient was recently admitted to the hospital for septic shock and received aggressive fluid resuscitation, approximately 5 liters of IV fluids and blood transfusions. That's like an entire human being, right?
Yeah.
That's your entire...
That's your circulating blood volume right there.
Whew, that's a lot.
Yep.
So they blew her up.
Yeah. I'm sure she even got more, too, with everything else.
Since discharge, she has noticed significant and progressive swelling in her legs, extending to the thigh and abdomen, and has been increasingly short of breath, especially when lying flat. She reports gaining over 15 pounds in the last week.
Sounds like me after crumble cookie.
Crumble cookie is good. Yeah. They aren't cookies. Those are cakes.
Yeah, for real, though,
Yeah.
right?
But they're amazing.
Yeah, they're delicious.
She has also been experiencing a marked decrease in urine output, feeling bloated. Well, I would think so. Past medical history is pertinent for severe CHF, CKD stage 4, type 2 diabetes, hypertension, hyperlipidemia. Quick recap. How do we define a CKD stage 4?
Usually GFR. So I'd say like a GFR about 15 to 29.
You all knew that, though.
Yeah, they definitely know that.
You already knew it.
100%.
We also have her on some medications. They consist of metformin, lisinopril, amlodipine, atorvastatin, insulin, and furosemide. Holy polypharmacy. It's a lot of medications.
Yeah, I know. They probably got one of those big things where they got pills for every day.
Oh, you have to. I would lose track of it.
Yeah, I know.
Yep. Vitals. We do an exam. We have a BP of 165/90, heart rate of 95, respirations 22 per minute, temp of 98.1, and O2 sat is 84% on room air. Woo, she's going downhill.
Yep.
We have an obese female, appears fatigued and severely volume overloaded. Cardiovascular, tachycardic, regular rhythm, S3 gallop is noted, and an elevated JVP. For respiratory, we have crackles at the lung bases bilaterally, decreased breath sounds at bases. Abdominal is distended with shifting dullness, mild tenderness present. Neuro, alert and oriented, there's no focal deficits, and her skin is a 4+ pitting edema. Basically, you're pressing in on this skin, and it's just a crater.
It's not going back.
It's probably not going to return.
It's not going back.
Yeah. So she really is volume overloaded, and we can even note that by her respiratory, right?
Yeah. So many factors
Some
here.
pulmonary edema, probably.
Pulmonary edema, pleural effusions, probably some ascites. So many factors.
We do some lab work. We get the following back. We have a creatinine of 4.8. At baseline, this was 2.5. BUN is 95. Hemoglobin, 10.2. Potassium, 5.9. Sodium, 130. Phosphate, 5. Calcium, 8.2. Albumin, 2.5. GFR of 12. Oh, my goodness. And a BNP of 2,500.
Yeah.
There's a lot of red flags out here, buddy.
Yeah. Just the labs are just ding, 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 ding.
This patient's in some trouble.
Yeah.
We do some imaging. Last thing here, we have a chest x-ray noted for bilateral pleural effusions, cardiomegaly, pulmonary edema. We have an echocardiogram performed. We have a severely reduced EF of 20%, moderate mitral regurgitation, and a dilated left ventricle. Renal ultrasound, bilaterally small kidneys with increased echogenicity, and no hydronephrosis present. Woo! I gotta take a breath.
I know, that was a long one.
She's sick.
She's not well.
She is not good.
No, she is not well. That is for sure, skis.
What do we have to do? How can we help this patient out?
Yeah, just send her home. No, obviously, we're going to do something, and we're gonna diurese this patient. So,
okay,
I definitely think that this patient requires aggressive diuresis.
Funny because Before, she required aggressive IV fluid, and now
Yeah.
flip the script
So
here.
you see what I'm saying? This is a common thing.
Yeah, it's unfortunate when you have to kind of just work backwards.
Yeah. I mean, they say like there's one of my attendings said you got to swell to get well and you got to pee to be free.
That's
So
cool.
so you'd fill them up with like 6, 7, 8 liters to get them to have a blood pressure because they were in shock.
Yep.
And then to get them off the ventilator and to improve them, you got to diurese all that fluid off. So
Double-edged sword there. You can't win.
yeah, so it's pretty common. We see this a lot in the ICU, but I'd say this patient's extremely volume overloaded. They got 4+ pitting edema. They got pulmonary edema based upon the chest x-ray. They got crackles on auscultation, which supports the pulmonary edema. They have shortness of breath when lying flat or when sleeping, so paroxysmal nocturnal dyspnea and orthopnea. Pleural effusions that are present on chest x-ray and the dullness to percussion. Elevated JVP, so that right heart, the central venous pressure is probably through the roof. And then on top of that, history of underlying CHF, history of like pretty much close to CKD5. So CKD4 is about this stage right now. So there's so many things that tells me that this patient is volume overloaded. So definitely needs to be diuresed pretty heavily.
What's your first diuretic? What's your go-to?
So loop diuretics are going to be your first line. So there's loop diuretics, thiazide diuretics, potassium sparing, and then there's carbonic anhydrase inhibitors. Whenever you have a patient who is hypervolemic like this, your first line is always going to be loop diuretics. So furosemide is an option, torsemide, bumetanide, but those are going to be the best because what they're going to do is they're going to work at the thick ascending limb of the loop of Henle. They're going to block the sodium potassium 2 chloride cotransporter. Not going to get sodium into the medulla, can't pull water out of the descending limb. So you dump tons of water and sodium into the urine, and over time that'll deplete your circulating volume, and that'll help with that edema.
Just for a quick little overview, just a recap in case they haven't watched our video on diuretics, just give a quick overview on where each portion of the nephron, each diuretic is working at.
That's a good point. Yeah, so usually with loop diuretics, they act at the thick ascending limb.
Okay, there's one.
The carbonic anhydrase primarily work at the proximal tubule, the proximal convoluted tubule.
Okay.
The thiazides or the thiazide-likes act at the early distal tubule, and then the potassium-sparing diuretics act at the late distal tubule or the cortical collecting duct. It's about the locations of where you work on those.
What's the diuretic that you can actually give for altitude sickness?
You can give carbonic anhydrase inhibitors.
I always find that one cool.
Yeah, I know.
It's
really
interesting.
It is really cool because the concept behind that one is when you go up to high altitudes, less oxygen. So you breathe really fast and you develop respiratory alkalosis. You give them a carbonic anhydrase inhibitor, and then they pee out bicarb. So then their pH in the blood becomes more acidic, and it kind of compensates for that respiratory alkalosis.
It's pretty cool.
Yeah, so they're actually supposed to, I think you're supposed to take that before you even start going up hiking in like Mount Everest or whatever it is to kind of get yourself to acclimate. But
what dose of the loop diuretic would you give, and how do you kind of monitor that to say, is it working or is it not working?
yeah, that's a good question. So there's lots of formulas out there. Like there's like the creatinine times 40 formula. So you take their creatinine, you multiply it by 40, and that gives you about the dose that you'd start with. Or you can do the House of God formula, which is like age plus BUN. I just like to start off, usually with a patient like this, I'd probably start off 80 milligrams. 80 milligrams IV furosemide is what I'd probably start off with and hit them with a heavy dose. It's also important to know that furosemide Lasix is the most commonly utilized one, but you can use torsemide. You can use bumetanide. You just have to remember that it's a 4-2-1 relationship. So for example, for every 40 milligrams of IV furosemide, it's 2 milligrams of torsemide and then 1 milligram of bumetanide. And so that's a really important thing, just knowing that conversion factor. But I would say start off with about 80 milligrams of furosemide if I don't get a good response. And what's that response? I'm looking for an increase in urine output.
Okay.
So I want to see this patient make at least more than 200 milliliters in the first 2 hours. So that's what I want to see. And if they don't respond to that, I'm going to increase the dose. Maybe I'll go up to 120 and I'll see if they have a response. If they don't, I'll go up to 160, 180, go up to 200 milligrams if I need to. But that's kind of the way that I'm going to look at that is I want to see, do they have a response? How high of a dose do I need? What's that threshold dose that I need to reach to get them to diurese out a good amount of urine? At least 200 in the first 2 hours. Once I get that response, then I keep a close eye on their I's and O's.
Yeah.
So I watch, I usually set a goal. So for example, let's say that I have a patient like this. I'd say, okay, they're volume overloaded. I'm going to start with furosemide. Let's give 80 milligrams now. Let's get them to have at least over the course of the next 24 hours, let's get at least 1 to 2 liters off of them. And so that's what we would do. And then I would also check their weights. So what's their weight today, tomorrow, the next day? And my goal is to get their weight to get back to what their baseline is, get 15 pounds off them, and to get them to have about 1 liter to 2 liters taken off of them every day. And so that's about what I would do. And then on top of that, I want to see, does this patient have improvement in their symptoms? Is their pitting edema shrinking? So if I stick my finger in, it's not going to stay like that forever. Is their lungs sounding a little bit better? Are they less short of breath? Is their oxygen saturation improving? So those are the things that I would start off with. Give a good bolus, reassess them throughout the day, and rebolus them with that Lasix or furosemide to get them to about 1 liter to 2 liters negative over a 24-hour period. Check their weights, see if their weights are coming down.
Yeah.
Keep an eye on their a lot of their symptoms and edema features, and then keep a close eye on their electrolytes. Because when you give heavy amounts of furosemide, you dump potassium. So you got to make sure they don't get hypokalemia, hypomagnesemia, stuff like that.
Let me float a situation your way. We do what you say. We're diuresing. We're providing them with the administration of furosemide.
Okay.
It's not working.
All right.
So we notice that the patient is still remaining with edema. Eyes and nose are positive. Weight is still up. It's maybe the dose isn't working. Maybe the medication of furosemide itself is not doing the trick.
Yeah.
What do you do?
So you can keep increasing the dose. I'd say until I get about 200 milligrams, I wouldn't go above that.
Okay.
What I would say is I like frequency. So I've found that frequency of the actual increasing the frequency of the drug is actually better than maybe increasing the dose. And so I've found that maybe, for example, let's say I start off with 80 milligrams and I pull off about 400 milliliters in the first 2 hours. Well, then I'll give it 80 milligrams 6 hours later.
Okay.
And then I'll keep giving it every 6 hours. And the funny thing is Lasix is just the brand name of furosemide is lasts 6 hours. So
that's cool.
You give that drug, you get its effect for about peak is about 6 hours. And then after that, redose it again.
Okay.
So that's kind of what I would start off with. First, I would keep going up in dosage until I get a good response. If I don't get a good response with that, just increase the frequency. Give it every 6 hours. And that usually helps to get a lot of fluid off. What I would say, and there's literature out there that people, very controversial, bolus versus infusion. Infusions, they're easy for clinicians. It's just more challenging for the nurses and the team because they have to keep an eye on that. So you set a rate. I'll do 10 milligrams of furosemide an hour, 20 milligrams of furosemide an hour. And I want about 100 milliliters of urine output every hour. If they're not getting that, let me know and we'll increase the rate. And so sometimes furosemide infusions can also be given as an alternative instead of bolusing it every 6 hours.
Okay.
So that's something else to consider. So I'd say go up in the dose until you can't go anymore, or increase the frequency. I prefer that better, every 6 hours. If that really doesn't work and you're just not getting any love, then I would say try a furosemide infusion potentially. This is very common in the cardiac ICUs. But what I like to do, preferably, is besides increasing the frequency, is I like to block other parts of the nephron. So loop diuretics, just one area of the nephron that I can block.
Yep.
I can add other ones. And so what I like to do is I like to go every 6 hours with furosemide, maybe 80 milligrams, and then add on a thiazide diuretic. So I like to add on metolazone. And so I'll give them metolazone, and metolazone will help to block the distal tubule, and it'll help to get rid of more sodium and more water, and that's the benefit that I like. So I like doing increased frequency and in decent doses, but then adding on metolazone to block another part of the nephron.
Let's say we decided to increase the frequency and dose of loop diuretics, like you said.
Okay.
How do we monitor the sodium fluctuations here? What do you do about issues with the sodium as we're dumping it out?
Yeah, so with loop diuretics, one of the funny things with this diuretic is that whenever you give this one, patients can get rid of more water than they do sodium.
Okay.
Because you're really blocking the thick ascending limb, so you're blocking sodium reabsorption, yes, but the descending limb is going to be where water comes out. And so if you're not reabsorbing sodium, you don't reabsorb a lot of water. And so you lose a ton of water. So what we found with furosemide is it causes a little bit more of an electrolyte-free water losses, so close to aquuresis. So these patients actually get hypernatremic with very frequent dosing and high doses. So when that starts to happen, it doesn't mean, hey, stop giving diuretics. They're dehydrated. It just means that, if they're still 15 pounds up, they still have 4+ pitting edema, they're still up in their weights and I's and O's, you still need to diurese them. that's a perfect indication to add on a thiazide diuretic.
Okay.
So thiazides get rid of a little bit more sodium than they do water. And so the risk of that is hyponatremia, but you can use the adverse effect of thiazide to treat for this benefit, which is I'm giving furosemide very frequently, high doses. Their sodium's going up, add on the thiazide because that'll help with the diuresis by blocking other parts of the nephron, but also get rid of more sodium, and it'll help to bring that sodium back down to normonatremia.
What if you're concerned with hypokalemia? Couldn't you give a potassium-sparing diuretic?
Exactly. So that's one of the beautiful concepts of this is that diuretics are so elegant. A lot of the times we just give furosemide and then we just don't do anything else. We're like, oh man, can't figure out why I can't get the fluid off of them, and I can't figure out why their sodium is 162 and their potassium is 0.5.
Yeah, there's more than one.
Yeah, so add on other ones, right?
Yeah.
So start with your loop diuretic, get your good frequency, get a good dose. Sodium's not, it's going up, add on a thiazide. Potassium, you're having to replace it. That's the annoying thing. When you replace potassium, sometimes we have to give potassium replacement in fluids. And so you're giving them fluids. So sometimes if you're having to frequently keep replacing the potassium and giving a little bit of excess fluid, go ahead and just add on a diuretic that will help to get rid of a little bit more fluid, but primarily spare that potassium loss. And that's where I'd add on like something like spironolactone,
Sure.
eplerenone, amiloride. Those are the things I would consider.
And how do these drugs work?
So they work by there's two of them. So aldosterone antagonists is spironolactone and eplerenone.
Okay.
They block aldosterone, so then they block sodium reabsorption, and then they help to block potassium excretion. And they also block proton excretion. So if you block sodium reabsorption, you'll lead to a little bit of sodium loss and water loss, so you get some diuretic effect.
Okay.
But you primarily block the proton and potassium excretion. So then the potassium can build up in the blood and normalize them if they're utilizing furosemide and thiazides. And it also can help to make the pH a little bit more acidic because you're not secreting protons. And funny thing is when patients are getting lots of furosemide and lots of thiazides, they dump protons into the urine. So they get alkalosis. So sometimes this can also combat the alkalosis a little bit too.
So if they are getting alkalotic, that's a perfect example to pop that on there.
Yeah, so you could do, for example, so this could be a regimen. Let's say that you start off with a loop diuretic, 80 milligrams every 6 hours of furosemide. You're trying to get that off. They're responding, but sodium is going up. Mm-hmm. Add on a thiazide. As you continue to do that, maybe they get alkalotic. You have two options, especially if they have hypokalemia. I would just go ahead and add on a potassium-sparing diuretic.
Fix two problems.
Exactly. But another option is if they're only getting alkalotic and they're not really getting hypokalemic, is you can consider carbonic anhydrase inhibitors.
Gotcha.
So you can give something like acetazolamide as an additional agent here.
At what point would you say, okay, oops, I've over-diuresed the living crap out of this patient. They look like a freaking raisin. They're shriveled up like no other.
Yeah.
What do you do? Like, do you hold diuresis at this time? Maybe they even require fluids now.
Yeah.
What happens in that situation?
That is a tough thing, right? So you want to make sure that the reason why they're in this mess is because they get over-resuscitated and they have history of fluid retention problems, CHF, CKD, etc. So what I look for is a couple different things. If I'm over-diuresing, I'm pulling off too much volume from their circulation. And so they're getting hypovolemic. And as a result of that hypovolemia, they're getting hypotensive. And if they're getting hypotensive, they're not perfusing their kidneys. And if they're not perfusing their kidneys, then their kidney function will start to increase.
Yeah.
And so they won't make as much urine. So what I look for is there any signs of hypovolemia? Are they having no edema anymore? And now they have dry mucous membranes, decreased skin turgor, hypotension, tachycardia. On top of that, no more any evidence of edema whatsoever.
Yeah.
That'd be kind of weird though, right? So if I went from like 15 pounds, pulmonary edema, everything, and I just completely went to no edema.
Yeah, it's a raisin.
I overdid it. So that's why you just watch and keep a close eye on that. So if the blood pressure's low, the kidney function, the creatinine's up, the BUN's up, they're not making as much urine, you overdid it. And especially if they don't have any edema, you got to stop. And you might even have to give them a little bit of fluids back. Yeah. But that's kind of the situation, what I would see. Another one is you can see this a lot with especially aggressive diuresis. I just would be careful. When you're diuresing, you can get severe hypokalemia, you can get hyponatremia, you can get metabolic acidosis and alkalosis. It doesn't mean that you need to stop diuresing them. You just may need to alter your sequential nephron blockade a little bit. So just be careful and keep a very, very close eye on their electrolytes, their acid-base status. But the primary reason to say to stop is I just overdid it and I made them hypovolemic. Or another reason to stop is you get right to that point where their weight's back to normal. They don't have any edema features anymore. Their blood pressure's good. So they're right at that perfect euvolemic state. So that's when I would stop. Oh, okay, I had them on 80 milligrams of Lasix every 6 hours. I had them on 25 milligrams of thiazide. I had them on 500 milligrams of acetazolamide, or I had them on, some type of spironolactone. When I get to those points, that's pretty aggressive. Yeah. If I get them to the point where now normal volume status, good blood pressure, they don't have any edema anymore, their blood pressure's good, their creatinine looks good, they look euvolemic. In that scenario, I may just back off of all of those drugs and just keep on a loop diuretic to just maintain, because they have CHF, they have CKD, they're going to retain. Yeah. But I may stop doing IV meds and just go back to their home dose of whatever their PO or oral furosemide was. Maybe it was 40 milligrams. And then I'll start that back up. So that's the ways that I would say, okay, don't need to diurese anymore. I overdid it. Stop.
All right. You also answered my next question. So I appreciate it. You're just very thorough. You killed it.
I appreciate that. I think it's important to know, again, with diuretics, what are you using it for? Which diuretics are you going to pick? What kind of complications can arise? Doesn't mean that you got to stop diuresing them. Just know how to alter your diuretic regimen. Know what to monitor for when it's time to stop. Know what to monitor for when I overdid it. And I think in these situations, you'll be a beast at dominating the diuresis.
Yeah, so. I like it. Your passion for diuretics is I love it.
I'd like to apologize for the behavior of my passion.
Yeah,
okay.
Yeah. IV fluids, diuretics, you love it,
man. Yeah, this is good stuff. This is ICU level stuff, so it's kind of fun. But
good.
Ninjas, I really hope that you guys enjoyed it, and I hope that you liked it, and I hope that this podcast was really fun and enjoyable. And I love you guys. I thank you guys, and as always, until next time.